Welcome to another week of Waye Endoscopy conference. Our first speaker presenter this morning will be Dr. Emily Leven.
Hey. Okay. So good morning, everyone. I'm Emily. I'm going to be presenting a 69-year-old woman. Came in, she had daily smoking, daily NSAID use. She was otherwise very healthy. She had been having a few days of constipation, was taking some Miralax, had been straining on the toilet, and ended up having a syncopal episode. Woke up and for the first time ever noticed bright red blood in the toilet bowl. It was her first episode of GI bleeding, and actually she had seen her GI very recently and was planned for a regular interval 10-year colonoscopy in the next couple of weeks. When she came to the emergency room, it was overnight. She was a little bit tachycardic. She had maroon stool on rectal exam. Her hemoglobin 6 months prior had been 14, but when she arrived at 11:30 at night, it was down to 11.4. Over the next several hours at 7:30 a.m., it was down to 9.9, and her BUN had also come down a little bit. She'd gotten a liter of fluids in this time. She's also gotten a CT angiogram. There was nothing on the arterial phase, but you can see here in the venous phase in the rectum, there was some enhancement there, suggestive of possible bleeding. So on her first assessment, she was eating a bag of chips. We asked her to start rapid Mobi prep. And so by about 2 o'clock, she had clear stools after 2 liters of prep, and she was in the endo suite by around 5 o'clock. On endoscopy, we did see some non-bleeding ulcers, some erosions, but no evidence of any sort of blood, old or new, nothing bleeding. On colonoscopy, we saw a lot of old blood and clots basically throughout all the way to the ascending. We saw some diverticula in the rectosigmoid, and we saw small internal hemorrhoids. And on the way back, we were trying to irrigate as much of this as possible to see if there was anything that was actively bleeding. And so I'll show some video here as we were doing the irrigation. That was just a picture. We started to see something that looked like a brighter red. And here at the bottom of the screen, you can see as we're washing, more bright red comes out. And there's blood coming out of that tick.
Maybe one day. So what happens?
We'll show you. So we're convincing ourselves that it is in fact what we think it is, and it is. There's active bleeding from this tick, and so we decide to go forth with clipping, and I'll show you the very exciting clips that we place. We decided to put 3 across.
Huh.
So this is the first one. And then I'll fast forward a little bit and you'll see the final product. Nice zipper ends up. See, there's like a little squinch of blood at the top here. And then we get the third one on. And we're done.
Like magic.
It felt like magic. It was very cool. Okay. So in terms of endoscopic management of diverticular bleeding, just a quick backtrack and reminder of the anatomy and pathophys. You can see here a little picture of the penetrating vessels from the vasa recta. It's actually little arterioles that are going to be bleeding. In the large majority of patients, you're going to have spontaneous resolution, particularly the less blood transfusion you need, the more likely it is that it's going to stop on its own. But there is a reasonable risk of rebleeding after the first episode. And most of these penetrating bleeding vessels are actually going to be at the base. Some are going to also be at the neck. Rebleeding rates that are reported are very variable, and some of that has to do with the fact that the reported technique for intervention varies pretty widely over time and across centers. So it's ranging from 0 to 38% depending on the study. So these are some pictures of endoscopic findings of diverticular bleeding. In A, up here top left, you see an actively bleeding vessel at the neck of a tick. Here at the base, you see a non-bleeding visible vessel. These two are the same tick. One is the clot, and then this is after the clot has been dislodged. You can see active bleeding afterward. Actually, wasn't able to find any RCTs with a head-to-head comparison in the most recent literature. It's mainly looking at clipping versus band ligation. And the main considerations are direct versus indirect hemostasis. So for those vessels that are at the base, it's going to be much harder to actually access the opening of the bleeding vessel. And so you might have to think about more indirect hemostasis, either with band ligation and sort of choking off that vessel, or clipping across the way that we did, versus if you have something at the neck of the tick, then you might be able to directly clip it off. Other things to think about is if you actually have to remove the scope to put the bander on, whether or not you're going to be able to find that area again. There are case reports of perforation within a few days of band ligation, but very, very few. Same thing with post-interventional sepsis. There was one relatively large systematic review and meta-analysis looking at band ligation versus clipping. There were over 130, 140 patients in each group. And there was no difference in rebleeding rates at the time of the intervention or within 30 days, but there was a statistically significant reduced need for either IR or surgery in the band ligation group. So that is something that makes me think that if you actually can technically get the bander there, it might be something to consider first. These are some pictures of clipping in the middle row, the sort of neck clip of direct hemostasis, and then the zipper fashion across the top on the bottom. Here's the bander, and you'll notice that they did place a clip here, even though they're banding, so that you can find the area on CT afterwards, should you have rebleeding. Cautery and epi are not recommended anymore, though there are a lot of studies from the 80s and early 2000s with it. And there's a recommendation to mark the area regardless of the technique in case there's rebleeding. It's worth mentioning, this study is a landmark paper from the New England Journal from 2000 with Jensen's group in California. This was one of the only prospective studies. They took two groups from the ICU in the 80s and the 90s. They did a very large amount of go lightly very, very quickly. And within 6 to 12 hours of presentation, they had people getting scoped at the bedside in the ICU, and they had to have known diverticular disease from a colonoscopy to be included in the study. And then only the second group ended up actually having endoscopic intervention, but in these 21 patients that they did either epi or bipolar cautery, they ended up having no rebleeding. And I think that takeaway that I thought was interesting here was that they found an actual bleeding tick in about 20% of those patients, but that even in these patients where you knew you had diverticular disease, the majority of them had some other source of bleeding. So I think main takeaways would be a rapid purge can sometimes help you find active bleeding. Many patients with ticks are going to bleed from other places, and you should think about band ligation or clipping and mark for future interventions.
But a majority of them, by your own statistics, stop on their own.
Yeah.
So I'm sure there was a discussion at the bedside of doing nothing. And also of the 21 of 21 that got better, how many of the other group never really bled? The group they did nothing to in that New England paper.
I don't remember for the second question.
You got to know what happened to the control group.
Our discussion about her, part of the reason that we felt that she should have some intervention was that she actually had a syncopal episode and she was continuing to have a drop in her hemoglobin.
She also hadn't had a colonoscopy in about 10 years.
Yeah. She was due for her 10-year in 2 weeks.
She got it.
Yeah, she sure did.
Were there any follow-ups? I didn't recall the follow-ups.
No.
The way I'll think about this is that, like, most patients, I think, as Peter's alluding to, follow the book. They come in with huge hemorrhage in the middle of the night. 12 to 24 hours later, they've stopped.
Yeah.
And then they're done.
Up to 80, you said 80%?
Yeah. Hey.
And I think the other thing that's reassuring for the overnight fellow is the Lauren Lane paper about the early versus late colonoscopy. So this was also using the sort of like ICU population where I think probably selecting for a sicker group of people who probably had more hemodynamic instability.
I also think that in her case, because I was on service when we did this, we saw her early in the morning, talked with her about doing a scope, and she was like, I'll drink everything. And so she rapid prepped the same day. So it sort of lined up with the Jensen paper, which we talked about when we were on service, that not everyone has, they have a separate bleeding team at UCLA. They'll rapid prep patients and think about how many tick bleeds we've seen collectively in our careers and how many have you actually found the bleeding diverticulum.
Right.
And in his study, it's 20%, which is absurdly high. And to your point, I think you don't always find them in the natural history as they tend to bleed and then they stop. But I think in her case, we, got lucky and found it. And we did put a tattoo also in the area. One of the other things that has sometimes been done is like an over the scope clip potentially, similar type of concept like band ligation, but in this case we didn't want to take the scope out and have to try to re-identify going back with a bander or an over the scope clip, and so we put a few clips on and then tattooed, and then she did okay.
The other thing is that the blood vessel goes deep inside the tick and around. You showed it in your own drawings, and this is sort of like sealing the mouth of the cave where the bleeding is coming maybe from deep inside the cave.
Yeah.
The vessel is like you showed a picture of.
Yeah, if it's at the base.
So I just wonder about how effective it is to just seal the mouth of the tick.
Yeah, I think in this case it was a smaller tick that you can see. Like it wasn't one of those like deeper ones. In which case I think then like a band ligation where you can invert it and choke it maybe a little bit better. But here it was very small. I think we felt pretty comfortable. If we had a cap on, I think we could have tried to probe it and open it up a little more to see. But we weren't. When we went into it, we were thinking we were just gonna see a lot of blood, rule out like a mass, and then have her run the course and then come back as an outpatient for another colonoscopy. But we were pleasantly surprised to find this. I'm sort of wondering collectively in the room how many actively bleeding ticks we've seen, because I'm at 3. One was like Emily, like in my first week of fellowship, or second or third week, and then this case, and then one other one.
Two.
Had one.
Yeah, so you see, it's like we talk about how rare it is to actually find that bleeding diverticulum.
I have one question from Zoom land. I found one during fellowship, and I guess my question always is, okay, we stopped the bleeding from this one tick. Is the rebleeding always from the same tick, or is it from other ticks? And have we actually changed any of the natural history of this problem?
Yeah.
I don't know. I think that the way that it was described in the literature made it feel like it was probably the same one, because all of the recommendations were to mark that site, which makes me think that probably the suspicion is that it's the same place.
I agree. I just don't know if that's actually true. What do other people think? Is that true? That it's always the same area, or?
Yes.
Well, I would say one additional point to add to this is, I was just on service last week, and I think we should give out sort of those frequent flyer cards like they have at the coffee shops. You can punch a hole in it, because the number of people who were having what were clearly lower GI, probably diverticular bleeds, were well known to the service. Frequent flyers, they just bled last week. So this non-rebleeding after 30 months, I don't know. That doesn't quite match what we see on our service here. So it could have been any of the ticks, in my opinion, but they seem to come back quite often. They're usually well known. They know the drill.
Yeah.
I wonder whether the natural history of bleeding cessation is the same now in the era where everybody's on anticoagulation.
Yeah.
I mean, everybody's on Plavix, Eliquis, Xarelto. Do they have the same spontaneous cessation of bleeding that we all grew up with?
Yeah, I mean, it seems like they do still stop. The question is it increase the recurrence rate? Maybe people have these subclinical low-level bleeds that occur that aren't an issue unless you're on DAPT. But I mean, so I've seen this study presented 1 million times at 1 million conferences, and everyone who presents it says, "Oh, by the way, this has never been replicated by anybody else."
Yeah.
Like that is the follow-up statement to this study.
Yeah.
Mm-hmm.
Something that's always amazed me is, and maybe other people can comment on this, people who have diverticular disease, they either bleed or they get diverticulitis. I have one patient in my career who had both, bleeding from diverticular disease and infection from diverticular disease. Is that everybody else's experience? Like you either get one or the other. I never quite understood why that is. I guess we'll hear about that next hour at Grand Rounds, but.
Yeah.
Segue.
That's true.
Yeah.
Nothing.
Good comment, Steve. Any other questions, comments?
Great.
All right, Kate.
Nice job. Thank you.
All right, our next presenter is Dr. Rabab Ali.
All right, hello everyone. Today I'm going to be on popular demand from all the fellows yesterday. This is a case that we literally scoped yesterday at the VA, and happy to hear everyone's thoughts about what they feel is the most likely cause of the endoscopy findings that we saw. So the case was a 68-year-old veteran who presented to the Bronx VA for 2 episodes of hematemesis at the nursing home. He was in the ED day before yesterday and had his 3rd episode of a witnessed 150 cc of bright red bloody emesis. Other than that 1 episode, he was hemodynamically stable. His hemoglobin was 12 at his baseline. He looked otherwise okay, so they admitted him to the floor, and the plan was to do an EGD the next day in the endoscopy suite. His past medical history was notable for advanced dementia, chronic alcohol use, unclear if he ever had cirrhosis, but that was definitely something everyone was worried about. And then history of seizure disorder, for which he was on phenytoin and Keppra. Other key history points that we learned were that he had a very similar presentation in 2018, where he presented to the Bronx VA for chest pain and coffee ground emesis, which self-resolved overnight. He still ended up getting an EGD the next morning, which was only notable for all blood, some clots, and then severe LA grade D esophagitis, no varices at that time. So everyone thought that his bleeding at that time was attributed to the severe esophagitis, started on a PPI and discharged. He was never seen again since 2018 till day before yesterday. He did, his mother did mention that he had a presentation in September this year at Montefiore for hematemesis, never got scoped, bleeding stopped on its own, and he was managed supportively at that time. So this would be his 3rd presentation now since 2018. Off note, we ended up scoping him in the ICU because yesterday, on his way down to endoscopy suite, he had a massive episode of hematemesis, large volume, aspirated, became hypoxic, requiring immediate escalation to ICU and RSI. Once he was intubated, we didn't even have time to give him erythromycin. We just went in. And this is what we found in the esophagus. So this is the proximal end of the esophagus, and there's this large, very deep, longitudinal ulcer running all the way down to the GE junction.
How difficult was the intubation?
I don't think
That doesn't-
they commented on it being difficult. And there was some old blood in it. We washed that off, and there was more bright blood underneath that. But as you can see there, there's like an overhanging margin of the mucosa, which kind of makes you appreciate how deep that runs. And then I'll just hit next because my video was moving a bit. And here, you should be able to see if I fast forward.
Did he have an NG? Did he have an NG tube?
No. No, they never had any NG tube insertion or any kind of manipulation of his GI tract prior to this. And
Had he been vomiting?
he had been, great question. He has advanced dementia, so hard to get a great history. And from the nursing home, all we got report was that he had 2 episodes of coffee ground emesis, but no retching or nausea, vomiting, like bilious before the hematemesis was reported. So that's where I would want to pause and ask both the Zoomland and here, when you see something like that, what comes to mind? How do you work through the endoscopic appearance of the ulcer? What's your differential? What do you think is the likely cause?
And the stomach,
Biliary-wise.
everything else was normal.
Sorry, so yeah, we went into the stomach. I don't have videos here, but the stomach was filled with old blood.
Yeah.
We tried to irrigate and suction it out. It was just copious large clots. So we didn't do a full examination of the stomach, but it all looked old, and the duodenum up to the second part was completely
And
clear.
where is that relative to the EG junction?
Yeah, so it's-
Is it distal esophagus?
It starts right at the GE junction. So here you can see, I think. It starts right proximal to the GE junction. That's
Already Weiss?
that's
Was
the,
he-
that's the GE junction right there.
Was he on Was he on a proton pump inhibitor because of his previous diagnosis of the esophagitis? And, okay, I mean, I think Borjas, when I look at this, I mean, this is a pretty deep rent.
Borjas goes all the way through.
Well, it looks pretty close.
Captain.
Yeah, I mean, Mallory Weiss to Borjas, right? I mean, like, I really wonder how much he was actually retching.
Yeah.
That's dramatic. That or iatrogenic, like with the intubation, but it's too far down for that.
Yeah, it went all the way down to the GE junction and we measured it. The GE junction was at like 37 centimeters from the incisors, and then this extended up to 28. So it was like 9 centimeters long.
Yuck. It's a long Mallory Weiss.
Yeah.
So anyway, the thing that we're thinking about is that based on the different etiologies of esophageal ulcer and inflammation, you can think of infections like CMV and herpes. You can think of him having history of severe esophagitis, which could be now complicated by just the ulcer propagating upwards in the setting of maybe retching or vomiting. He wasn't immune compromised, so having CMV or herpes would be unusual for him. A large Mallory Weiss stare, again, history was limited because he didn't have any history of retching. He was a heavy alcohol user, which can be a risk factor for having Mallory Weiss stares to begin with. And apparently, based on literature, I found that having worse, large Mallory Weiss stares is more likely in people who have underlying portal hypertension or cirrhosis. Although he didn't have that, he was coagulopathic with an INR of 1.6, and his platelets were low hundreds. We didn't find varices, but maybe he had some underlying liver disease, not really clear. And then could this be malignancy? And then the only other thing I found on differential would be pill-induced esophagitis, but he wasn't on anything that would cause something like this. And then of course, at Sinai, you have to mention esophageal Crohn's. And I did find some case reports that I will show some pictures of that can look a lot like this. So these are pictures from the patient that I just want to kind of zoom in to see like the important features that you look at to work through a differential for these kinds of ulcers. And I think for me, the most important point is like, is it an acute process or a chronic process? And based on the appearance of the ulcer, what you can appreciate is it has undermined edges, it has a fibrotic base, it's red, but it's not like really angry and raw. That suggests chronicity to me. Such a wide ulcer, if it was acute, I feel like it would have just perforated through the entire esophagus. So having such a wide, deep ulcer that's still with an intact wall, could that suggest chronicity? And then him having 2 prior episodes, could that suggest this is a long-standing process? So with all of that, I think that Mallory Weiss is a great differential, but it seems to us, and I would love to hear everyone else's thoughts, is something more chronic and long-standing. And looking at the literature, there's actually such a thing called giant esophageal ulcers. And the 3 leading causes of that, 2 big ones, are CMV, and the pathophys is actually interesting. So CMV infects your serosal cells, so it spares the mucosa completely, and it digs deep into the submucosa and can penetrate all the way into the muscularis mucosa. So you get this healthy overhanging mucosal edge with a deep cratered ulcer underneath with some white exudate in it. And it can become extremely large. Usually one single longitudinal ulcer. Esophageal Crohn's, like I said, this was a case report of a 22-year-old woman who presented with hematemesis. They found this large ulcer in the esophagus, didn't do anything at that time. Herpes and CMV stains were negative. And then 4 years later, she presented with ileocolonic disease. And in retrospect, they biopsied her esophagus and it was also consistent with Crohn's. And then the third most interesting differential I found on literature review is this thing called HIV-associated giant esophageal ulcers, which to me look a little similar, at least this one in A, to our patient, and this one in G and H. And this was a study that was published in this journal in 2016 by China, where they looked at 16 patients who presented with these large ulcers on their EGD. They stained the ulcers for CMV, HIV, and herpes. And what they found interesting is that only 2 patients had CMV, 2 had herpes, and the remaining 12 had HIV RNA in the tissue that was obtained during biopsy of those EGDs that they did. And that's important because these giant esophageal ulcers are highly prevalent, it seems like, in patients with AIDS, and 40% are associated with CMV, 45% are idiopathic, and are thought to be just an AIDS-associated ulcer process. And this is in another important table, another interesting table I found that kind of shows you that these giant esophageal ulcers can be seen in HIV and CMV, and they're deeper, more profound, and usually single when they're associated with HIV. Again, our patient does not have HIV, we're checking for it, but to me, that seems like maybe the most consistent finding. And then one important thing to mention is you can think of malignancy as well, which can be misdiagnosed in this situation. But again, malignancy is more irregular shaped, multiple sizes, and then is found typically, it sounds like, in the middle part of the esophagus, so maybe less likely. But yeah, with that, I think the questions I have to pitch forward to you guys is, would you repeat? So the big question we are debating, this happened yesterday. So he's still intubated in the ICU, and he could easily have another massive episode of hematemesis, and then what? Would you do another EGD and biopsy the margins of that ulcer? Would you empirically treat him for CMV? And then, of course, the next question is, why would you have CMV if you're not immune compromised? And then if he rebleeds, would you do an EGD and intervene, or would you call IR or surgery?
Have they done a chest CT on him yet? I'd be interested in seeing that.
So what did you guys do? You didn't take any biopsies, just looked and scope out?
No,
Didn't touch
yesterday,
it?
yeah, this happened like yesterday evening, and no, we did not take biopsies. He had just actively bled and his INR was a little elevated, so I think we just decided to come out. But the plan was, because we didn't visualize the stomach well, to go in again to clear out the stomach and then maybe biopsy then.
And he didn't have any crepitus or anything that would be concerning for, injury through the muscle?
Not on exam, and he wasn't, like, if we're worried about Borhaus and mediastinitis, he wasn't septic or unstable. It all, like, acutely he became unstable yesterday, but he was, like, sitting on the floor completely fine day before yesterday.
Could a foreign body do this? Any kind of if he swallowed something inadvertently?
Oh, you forgot to mention his hobby of sword swallowing. That was the secret historical pearl, right?
Yeah.
So what are thoughts? Would people repeat EGD and biopsy?
Yeah, I mean, chest CT, and I'd like some tissue.
Yeah, I think he needs biopsies.
And would you margin biopsy the margins?
Yeah, right.
That
Yeah,
ulcer?
yeah. I mean, in terms of intervention, does Advanced even have a clip big enough for this kind of thing?
So,
it was massive. I couldn't even see where the bleeding was coming from.
Yeah, I mean, there are wider jaw clips and newer clips on the market that, that could potentially be used to close this, but, it kind of almost looks like a poem tunnel where we're just looking at like muscle, without the closure. So, it's sort of debatable whether you want to, go in and close it or not. I think if you rebleed, I think then you sort of are obligated to.
And you would close along the whole line?
Yeah, just zipper close it. But I think the biopsies are going to be important here. I thought when you were presenting it that I think Steve asked the question, like, did they try to put an inch tube down and just cause trauma in that longitudinal fashion? I don't think, ET tube intubation, they wouldn't be able to reach that down that far. So it probably would have been maybe an inch trauma, but I think it's pretty important biopsying and sampling to see.
Wait, give me 1 second.
Today I'll be presenting a case of a 66-year-old female with coital cholestasis who had 2 outside ERCPs with left hydraulic lithotripsy done and had incomplete clearance of her duct, and so she was referred to us for the laser lithotripsy. So first, before going to the video, I will be referencing the Jerome Waye stone classification system, which is the Sinai way of defining sizes of stones. So our little berries. This was a case that Nikhil and I did a week ago. This is a Jerry, so a medium-sized stone. And then that's a Jerome. And so this talk is about the Jeromes. So starting off, you can see that a sphincterotomy is already done because the patient had had multiple prior RCPs. And we're inserting our coin disc into the bile duct here. We always watch the scope insertion with fluoro. And we also, you'll see as we toggle to the SPY view here, where we can see the bile duct, and as we advance up in the common bile duct, you see multiple stones kind of stacked in the duct. So then we insert the laser probe through the biopsy channel of the SPY. SPY is like a tool we place through the scopes, the duodenoscope biopsy channel. And so inside the SPY's biopsy channel, this is an even thinner fiber that goes through and delivers energy to fragment the stone and break it apart such that we can use standard stone extraction balloons and baskets to remove the stone after. So you can see that we're making holes on the side, trying to fragment the different sides of the stone. And this whole case took us maybe like 2-3 hours. So it's a long process depending on the number of stones that there are. You can also see that in the medium we use here, it's always saline for SPY, but for EHL, it's actually important to use the saline in order for EHL to work, which I'll touch on in a bit. So finally, after we fragment stones, we use a balloon to extract some Jerrys. They're not Jeromes yet. And then we, so that's a water-based balloon that we use initially. It's injectable, then we switch to stone extraction balloon that you there, removed another borderline Jerome. Then we did an occlusion trying to then see, what was left for us. And you can see the intrahepatics aren't filling that well, but it's a huge duct. So initially, we were like, unclear if we cleared everything up top. There's clearly some fragments in the mid CBD there. So we take out some more stones. Then we insert a larger balloon and inject more contrast, and then you can see the Jerome that's sitting in the duct there. It's massive. And definitely needs some sort of mechanical or SPY-based lithotripsy. So we went back and tried to break the stone up further, but we were not able to fragment it in order to even sweep fragments out. So ultimately we decided for this patient to place a stent. So we placed a covered metal stent across the stone with the goal of kind of crushing the stone and fragmenting it with time, but also to ensure biliary drainage from the top. And then we placed a coaxial plastic pigtail through there to reduce the risk of migration as well. And you can see some covered metal stent being deployed here. And there's our double pigtail. So this patient is scheduled to come back for removal of the stents and further clearance of the ducts in January. So
the stone is still there, right?
There's one big stone
there's
still
one big
left.
stone still.
And it's now above the stent?
No, so basically the stent is, you can see the stent kind of crushing it here. Like this is the stone and the stent is kind of going alongside it and putting pressure on it. I mean, the goal of this is to basically allow bile to drain above, because if you put a stent below, this stone can like lollipop is what we call it, like basically sit on the top and not allow adequate bile flow. So one advantage is to allow bile flow, but also to crush it with time. So today I'll be talking about difficult biliary stones, and the definition is variable in the literature, but one I found was that usually they're large stones above 15 millimeters in size, multiple, as you saw in our patient here. Difficult locations to get the stone out of, difficult shapes if they're very hard or impacted. So standard tools for stone extraction include the stone extraction balloon, which you've seen in my presentations before, a trap basket, which is used to remove smaller stones because you're not able to crush with this basket. You place the basket into the bile duct and you just kind of sweep out stones that are, maybe slipping around the balloon. And then you can use balloon dilation to help crush stones and to perform sphincteroplasties. But so that's what we use for standard smaller little Jerry's or Jerry's. But for Jerome's, then your options are to extend the sphincterotomy if possible, to do a sphincteroplasty using a balloon. There are many sizes of balloons you can use. Typically use a 10 millimeter balloon. And then, there are options of actually crushing the stone. So you can use mechanical lithotripsy or cholangioscopy-guided lithotripsy, EHL or laser. And then the other options are stenting, like we used here, kind of an auxiliary tool. And then there's as well, which I'm not talking about today. So mechanical lithotripsy is widely available, it's inexpensive, and it's pretty effective. In the index ERCP, you can usually clear 50 to 80, there's 50 to 80% of cases have full clearance of the stone. But if you do this for a couple of ERCPs in succession, usually you can achieve quite a high clearance rate. And just to go over the tool itself, it looks like a track basket, but it has a catheter that goes through the the crank here, and the tech cranks the catheter so that it comes through and kind of crushes the stone so that the stone like mechanically fragments. So this is a little finicky of a device. It takes some time and skill to be able to use the device, but also to capture stones in the bile duct itself. And in our group, typically only Jawad uses mechanical lithotripsy. The main issue is that if the system fails and you have a stone stuck in the basket in the bile duct, then your entire equipment is stuck because you can't extract the stone and you can't extract the device. And so that can lead to a lot of anxiety, and the patient may have to go for surgery to take this entire contraption out. But there is a device that you can apparently insert through the mouth to cut the basket, which Joanne knows about, but I'm not really sure. We don't typically use this in our group. Cholangioscopy-guided lithotripsy, though, we do use. So there's two types, EHL and laser lithotripsy. So electrohydraulic lithotripsy is bipolar, which means the patient doesn't need to be padded, and it generates sparks underwater and subsequent hydraulic pressure waves to fragment the stone. So it's actually important that you keep the catheter tip a little, like 2 millimeters from the stone itself. You don't want to be rammed up against the stone. Laser lithotripsy is using a flexible quartz fiber, which is the laser probe that goes through the biopsy channel, and it delivers the pulsed laser energy that you saw in the video to generate mechanical shock waves to fragment the stone. And you also actually don't need physical contact with the laser lithotripsy. So I'm going to present this paper, which Sinai contributed data to, which investigated the safety and efficacy of using cholangioscopy with EHL and laser. It was a retrospective analysis of about 400 patients from 22 tertiary care centers, where there were about 300 or so with EHL and 100 with laser lithotripsy. And the main goals were to look at the technical success defined as bile duct clearance, and then to look at the safety of the two techniques and compare their efficacy or their effectiveness. So procedural outcomes you can see here. So the technical success, which was ultimate clearance of the bile ducts, was 97% combined between the two groups, but the two groups had quite comparable technical success where both were able to clear the bile ducts. And in 77% of the cases, you just needed one session of one of these techniques to clear the duct. But that ranged between 1 to 4 sessions in total. And for 11 patients, they were unable to clear the duct with EHL and laser, so then they went on to needing either as well or surgery here. So between EHL and laser, as I said, similar technical success rate, and their adverse events are also quite similar. They had a total of 15 patients who had adverse events. 6 had cholangitis, which only 2 needed hospitalization with IV antibiotics. 1 had pancreatitis, 1 had bleeding, some transient bacteremia. 1 had a bile duct perforation, which is a concern with either of these techniques because, and that's why it's so important to visualize the stone when you're going at it with either EHL or laser, because if you touch the bile duct wall with either of them, there is a risk of bile duct perforation. But it's typically treated with a fully covered metal stent, which will close that hole and the hole heal with time. And then 5 had abdominal pain. But the major difference between the two was that laser typically EHL typically took a longer time, and laser took almost half the time. So the take-home points here are that you want to either increase the size of the outflow tract with the extension of the sphincterotomy, sphincteroplasty, or decrease the size of the stone with mechanical or cholangioscopy-based lithotripsy. Both EHL and laser have similar efficacies and safety rates, and you should use the JDW classification system by cyanide.
I'll preface that with, that's an internal classification
Yes.
system. So if you go outside and you're like, oh, there was a Jerome, but obviously we love Jerry and we've kind of standardized it internally of the Jeromes need lithotripsy. There's a question, I think maybe I saw Dr. Katz wrote, this patient needs surgery. I disagree. I think, this is the first laser session. There were multiple large, big stones. We cleared, I think, 2 of the bigger ones out. There's 1 big one left. I think we should be able to get rid of that last stone in 1 additional ERCP session and be able to spare her a surgery. But in cases where lithotripsy fails, then you may have to consider alternative options, which could include either other types of endoscopic drainage or surgery. But I think in this case we'll be able to avoid it for her.
What do you think the
Is there
etiology
Go ahead.
do you think the etiology of the stone, these are primary common duct stones or secondary common duct stones?
I think that the stones have developed secondary to the large duct size. The ducts are just lithogenic with sludge forming and stones forming with time. I think this patient had already had their gallbladder removed, so yeah.
So I think in primary common duct stones, the problem is drainage, and I think that's why we would generally send these patients to surgery.
Whereas actually,
That's a huge stone and a huge duct.
So you would do like a HJ?
Oh no, we do a choledochoduodenostomy. It can be done laparoscopically.
I don't think in this case that's going to be necessary. I think if we clear the duct, then we can see her and assess her. The duct should decompress from there.
This is all being done as an outpatient. The patient was very stable with this as well. So, we could technically do a few more sittings even if necessary.
Let us know.
We'll agree to disagree.
The surgeon.
Surgeon wants to cut, endoscopist wants to do endoscopy. Any other quick comments or questions, just in the interest of time? I know we have grand rounds coming up.
When you deploy a stent like that next to the stone, are there concerns about eroding through the wall, creating fistula or anything like that? Or
generally not. Usually you want to ensure that there's appropriate biliary drainage, which is why we terminated the proximal end of the stent above the stone, because otherwise, as Deepika alluded to, if the stent is below the stone, especially for a metal stent, it'll ball valve, so it'll just sit on top and prevent drainage. So we terminated above it, and then you'll have that radial force of the stent as it expands, so it will put some pressure. But what I have tend to found with these metal stents, with large stents of duct, is there's also sort of friction and erosion that occurs, which can sort of chip away at the stone. It would be very rare to form a fistula thereafter. So I think she's coming back. We were bringing her back in 4 to 6 weeks. I think she's coming in early January. And I think we just have one other big stone that's left that you can see. We'll do another session of laser, and then hopefully we should be able to clear the duct from there. And then ideally she'll be, stent free, and that duct should hopefully start to decompress from there.